welcome to this ad hoc committee meeting on COVID-19 of the Western Cape Provincial Parliament. I'd like to welcome the members present, the Provincial Minister of Health, Dr. Mbombo, the head of the Provincial Health Department, Dr. Christie, as well as officials from the Provincial Department of Health that will be briefing us today. I'd also like to welcome members of the public and the media that are joining us on the YouTube platform. I'm going to start as usual with some apologies. We've received a number of those from Honourable America, Heron, Maseko, Syed and Dugmore. And we welcome our alternate members who are standing in today as permanent members, Honourable Ricardo McKenzie and Honourable Lorraine Buerta. Are there any other apologies to be tabled at this stage? Ms. Hassan Musa?
Thank you, Chair. Through you, Member Mkondlo has also tabled an apology, and Member Bosman.
Thank you very much. We'll note those apologies in our minutes. Members present, I'd like to make a small addendum to our agenda today to include consideration of the draft committee activity report for the month of February 2021. Are there any objections?
No objection from me.
No objections.
Thank you kindly.
No.
We'll then add that towards the end of the agenda when we're considering minutes. Thank you very much for your indulgence. I now have to quickly go through the rules of engagement for virtual meetings. All members were muted at the start of the meeting to avoid background noises. If members could please flag points of order by either using the raise hand function or using the chat box. We ask that all video and audio be switched off to improve the quality of the connection. However, if a member or official or minister is speaking, please do feel free to use your camera and of course your microphone. We ask that presenters, once they have concluded the presentation, would unshare their screen so that we can then have a camera view of the presenter speaking. And of course, the maintenance of order in this meeting is directed by the Directors for Sittings of the House and Meetings of Committees by electronic means, which was ATC'd on Friday the 17th of April 2020. So today, as the Ad Hoc Committee on COVID-19, we're being briefed by the Provincial Health Department on two very important issues that are on everybody's minds as well as everybody's lips. And the first of that being, is there a third wave on its way? And secondly, how is our vaccination program going? And when can residents expect to receive their jabs? So on that note, I'd like to extend a very warm welcome to the Provincial Minister of Health, Dr. Mbombo, as well as the Provincial Head of Department, Dr. Christie, and to your teams. Thank you very much for being with us this afternoon. I will start with Minister Mbombo and ask if there are any introductory remarks that you'd like to make.
Good afternoon, Chair, members, honorable members, and also those who also staff from the department, and also those who might be online. I think without wasting much time, I'll just say just few words, and then I'll ask Dr. Christie to do the presentation. Under the two items that you have asked us to present, regarding the third wave, there is uncertainty in terms of whether or when and how it's going to be. It's all depend on the modeling, and it becomes difficult because of the variant, and it becomes most difficult because even the variant that we already have, which is the 501 YV2, there might be some more mutations in regard to the virus itself. So it becomes difficult. Two, it becomes difficult also to ascertain when and whether, because with the vaccination that is happening now, although it's still the phase 1, only for healthcare workers, about 500,000. If now there might be phase 2 that could come earlier, in terms of vaccinating the community, it may mean that there might be some delays in regard to the third wave if there might be some people who might have been vaccinated. And then also 3, it's in regard to the mere fact that the antibodies, there are many surveillance tests that are happening, whether it's a serology, where they're taking blood to determine whether antibodies and so forth, and also inclusive of the water sewage testing. You find that even with a blood bank, where I think that Dr. Christie is going to present that, you find that there are many other areas, specifically in the poor areas, not only the Western Cape, but even in the Eastern Cape and KZN, where you find that they have determined that actually some people already have the antibodies, reflecting that some people actually might have been, there might be elements of immunity. But whether that they will ended up being exposed to the virus, nobody knows. But yesterday, with a presentation by the MAC, the Ministerial Advisory Committee from the National Health, plus also the researchers, they indicated that the current evidence, it does show that for those people who have been exposed to the variant, it does show that actually they have got some immunity that can neutralize another exposure where a person might not necessarily be reinfected. But there's uncertainty in regard to, like, you will never know whether we have been, when we were positive, it was a COVID with a variant, or it might have been the first wave one where the variant was not there because it was only picked up, I think, towards the end of October. So I've got all of those uncertainties. So when we do the presentation, it's mostly based on what the data is currently. It doesn't mean at the end of the day or next week, things might not change. And then lastly, Chair, this is not a rollout because we have to name things correctly. Because when you say it's a rollout, it means that there is a vaccine that has been approved, commercialized, approved, where it could be rolled out to the citizens. What we are presenting, it is the phase 1 of the implementation study, 3B by J&J, Medical Research Council, supported, which forms part of the partnership together with the National Department of Health. So that's why when she does the presentation, people must understand in terms of why it's crucial for to be able to know who's being vaccinated or not, because it's part of the implementation study, because the J&J has been approved for now as an emergency approval as part of the implementation study. It's not necessarily the rollout per se. The rollout, which now once the J&J has been approved, as you heard from the president last time when he was opening up the lockdown, he indicated that the country has purchased, I think, 11 million doses for J&J, and about 2.8 million are expected to arrive in the second quarter. So that's when we could be able to talk about the rollout. For now, it's still part of the 500,000 for the whole country. And then for us, as the HOD will be presenting, where we are getting the 13,000 plus of the doses. So thank you very much. Over to Dr. Casey.
Thank you very much, Minister Mbombo. Warm welcome to you, Dr. Christie. Nice to see you again. I'll hand directly over to you. Thank you.
Thank you, Chairperson, and thank you to Minister Mbombo for the introduction. And thank you and good day to all the all the members, honourable members. I'm joined by Dr. Chris Vallabji, Chairperson, and I just want to give Dr. Vallabji and the team credit. They've, in large part, prepared this presentation, so thank you for that. So, Chairperson, can you see the slides?
Yes, we can. Thank you.
Okay, so I will proceed. So it is what has been forwarded to you has been quite a lengthy presentation. What I've done today is just give you an update with some updated slides as of this morning. but the content is very similar to what was previously circulated, and the updated slide has also been circulated. I just want to be very clear, Chairperson, in terms of the time and respect the time allocation. Can you please give me an indication how long I've got?
1 hour, please.
Thank you. I will be done within that. So thank you, Chairperson. I will start with some introductory comments, then assessing the risk of a third wave, as the Minister rightfully has indicated, then the containment and mitigation strategy for such a third wave, then to talk about the COVID-19 vaccination rollout program, and as Minister Mbombo rightfully said, the rollout of the J&J Sisonke program, and really making a distinction between the rollout program and the access program under Sisonke. And then the planning for phase 2 and 3 of vaccination with some concluding remarks. So in the introductory comments, I think it is very important to stress to the committee that we are now at a very historical moment of our time to really turn the tide against this pandemic. The last 3 months has represented, I would say, an unprecedented global response from the scientific community that enables us to turn the tide against the pandemic globally. So mass vaccination is the central weapon. It is there to reduce mortality, to protect the health system from being overwhelmed, and achieve adequate population coverage, commonly known as herd immunity, to reduce ongoing transmission of this virus. But there is a very real risk of a third wave, as we will not have achieved herd immunity in the next few months. The risk is accentuated by a range of potential factors, which is, as the Minister has pointed out, I'm sorry about that, Chairperson, is viral mutations, greater population movement as restrictions get lifted, COVID-19 fatigue, and the reduced vigilance against the good things that Member Maria was referring to, the hand washing and the mask wearing and the distance, and avoiding crowded places, and then the winter season when people tend to stay indoors. Then there's a real sense of urgency to blunt the impact of the third wave. So if we could, we would like to do everything in our power that we have a less of an impact in the third wave. And then the success of the mass vaccination program is going to require each one of us to play our role. It's the single biggest social mobilization drive, I would say, that all of us as society will have. So everyone in each of our respective workplaces, as well as ambassadors within our communities, is to encourage our people to vaccinate and to collaborate across sectors, across communities, and government and the whole of society. So it's really a time for what I would call unprecedented unity and solidarity towards one single purpose. Therefore, it's important, the importance of a collaborative governance structure that we have now brought together in providing oversight. So just to share with you the data, we send this to the committee all the time. So just to update you, this is the data as of 2 days ago, that we're truly coming out of the second wave. You see all the markers on the right-hand side. The green is the oxygen use. You can see a reduction in our daily oxygen use. You can see a reduction in hospitalization, reduction in deaths, and reduction in cases, but ultimately also a reduction in the test positivity rate of all the tests sent to the laboratory. So now going on to assessing the risk of a third wave. So the National Ministerial Advisory Technical Working Group also has the Western Cape epidemiologists on the group. So I really would also like to just give a credit to all our experts, all our scientists, our epidemiologists that's worked, and the collaboration with all other experts in the country. The team has worked together and they're guiding the country as a whole and not just each province doing its own thing. So the third wave is likely, but there's uncertainty about the timing, the location, and then the magnitude. But it will be driven, we all know, by 6 key factors. The first one is the change in viral transmissibility, and that mainly is going to be influenced by seasonality and what we would call the change in weather and the change in season. So going into winter, it changes the behavior patterns of society. So in summer, we're more outdoors, we do things outdoors. In winter, we tend to be more indoors. And if we are driving in taxis or in trains, we tend to close the windows. So the behavior associated with seasonality is going to play a big role. And then also seasonal behavior that's associated with long-standing things such as long weekends, funerals, Easter, all of those things will play together. The second big factor is behavior changes in the population. The big issue here is shifting back to level 1. We have experience of after the first wave going back to level 1, and the behavior change that came with level 1 is when the restrictions were released. What it meant is people also relaxed their behavior. So as we lift the restrictions to encourage the economy to grow, people take that as a place of going back to relaxed behavior, that we can forget about mask wearing, forget about social distancing, forget about avoiding crowded places. And that is a big challenge that we have to do, is to deal with the behavior. That level 1 doesn't mean we must drop the behaviors. It actually means if we go to level 1, we must be stricter on the behaviors. The third big issue is the change of what is called interactions between weakly connected subpopulations. So it's technical to language, but one of the big things that drove the second wave was the movement of people and the cases and exposure between provinces, also between, let's call it rural and urban, the city and the rural areas, but also movement of people from relatively wealthy suburbs to poorer suburbs. So we need to be constantly aware that this movement plays quite an important role of how the virus spreads. The last three is a little bit more technical in light of where we are now, and that is the changing immunity or the reinfection risk. So as the minister has indicated, if you are infected with COVID, everybody that has been infected has some antibodies inside of them and therefore have some level of immunity. And we have evidence to suggest, and we will share with you today to explain how come certain areas that were hard hit in the first wave were relatively less affected in the second wave. And we've got some data to prove that immunity probably played a role in that regard. And then the big scientific issue is that we have scientists that are now tracking and looking at the genome of the virus and changes within the genetic makeup of the virus. And the big thing is the potential for other changes to also come into this. And then the last one, the speed and the uptake and the impact of vaccinations could impact on the impact of the third wave. We know that this is going to be a big challenge for us in the coming weeks and months, so that we want to do it as quickly as fast to have an impact on the third wave. So if you put all of this together, what we are saying is, although immunity has likely increased, the rapid and simultaneous curtailment that came in for wave 2 suggests that a combination of restrictions that were implemented just before the peak, behavior change, school closures, all of those have been important contributors, and not just the fact that we have immunity. So if you all remember, in the 28th of December, President Ramaphosa introduced the alcohol ban, level 3, and curfew. And it is remarkable that within 2 weeks, everywhere in the country, the reduction was simultaneous. Everybody came down. So you can see the impact of restriction of movement that came from level 3 and the alcohol ban and the curfew. So all of that together. So it's not just immunity, it's also the restriction that played a role. Therefore, this actually points to us that potentially immunity is not equal everywhere, which I will show to you now. So if you go then to this issue about prevalence of what we call seroprevalence. Now, this is a study done by the blood bank. And what they've done, they have taken blood from people that are blood donors in January this year. And they've taken the blood and tested it for antibodies. And they've done it and divided it into the different racial classification, the racial groups. They've done it, and the results here is for Eastern Cape, Free State, Northern Cape, and KZN. They are still doing some follow-up work, and they will probably release some data for Western Cape and for Gauteng later. But this is the 4 provinces that they've done. And what you see on this graph, if I can just explain the graph to everyone. On the bottom, it shows the W is for white, the A is for Asian, the C is for colored, the B is for African black, and the total, or T, is for the total. So if you look at Eastern Cape, what this means is of all the blood donors in the Eastern Cape for which antibodies were tested, amongst African blacks, it was nearly 70%. 7 out of 10 people had the antibodies. But if you look at all the people of the Eastern Cape that were white, that were blood donors, it was less than 20%, 2 out of 10. That's a huge discrepancy in terms of antibodies between 2 groups. If you go to KZN, it was nearly 60% in African black donors, but also again around 15 or even 12% for white. What is interesting is that Northern Cape and Free State is in between and not as high, because as I showed you in the previous graph, when the lockdown came and the restrictions came, it actually stopped the transmission in Free State and Northern Cape, because you can remember that Eastern Cape, KZN and Western Cape preceded the lockdown. So it's also indication that when lockdown came, that fewer people were exposed and therefore the antibodies were less. So this is very interesting, that the pattern of inequality and spatial geography might then result in ongoing risk that differs by location and socioeconomic status. So if we take the racial groups as a proxy for socioeconomic status and geographic area of where people live, you can then extrapolate that depending on where you live and depending on your socioeconomic status, the exposure to COVID results in a higher exposure rate and therefore higher infection rate, therefore higher immunity that follows from that. So if we then bring this back to the Western Cape, so this committee and many other places, people have always asked, why is Kailua so much lower in the second wave compared to the first wave? Now, what we've done is we went back and we looked at all the people that we got routine blood samples from that attended for diabetes care. And we took those blood samples and then did antibodies on them at the end of the first wave. The picture that we got here is that of the people that came in for diabetic care, of whose blood samples we tested for antibodies, nearly 50% of them had evidence of COVID infection or antibodies. If you compare that to Eastern, Northern, and Southern, in Southern it was nearly 15%. Eastern and Northern less than 25%, and Western less than 25%. If you look at after Kailua, the second highest one was Klipfontein, and it's interesting, I'll show you in the next graph, that there's a correlation between antibodies following the first wave and the size of the second wave. And then you can see Mitchell's Plain and Tygerberg after that. What does that mean? So here's a graph to show you the correlation. So if you go to the left-hand side, it shows the seroprevalence. So that's what I just showed you amongst the diabetes patients, 50% for Kailua. But we also then compared it to how many people died per million in Kailua. So you can see there was a high death rate in the first wave and a high seroprevalence on the diabetic blood after the first wave. That is Kailua. You can see Klipfontein had the second highest for antibodies of the diabetic blood, and also the second highest in terms of deaths from the first wave. And you can see Mitchell's Plain was the third highest for deaths and the third highest for prevalence of antibodies. So there's a clear correlation between that. If you then go to the second wave, the second graph says, what was the ratio of the second wave to the first wave? One is if the second wave was equally as high as the first wave. So you can see the only 2 places that had a lower second wave than the first wave is Kailua. Again, Kailua with the 50% blood from the seroprevalence. Klipfontein had, so Kailua was almost twice as low. Klipfontein had about less than 80% of the second wave was 80% of the first wave, and Mitchell's Plain was just above 1 on 1, and then the rest, with the lower prevalence, had much higher second waves. So that does explain that in Kailua specifically, there were greater antibodies following the first wave. Therefore, there were more protection in Kailua. So just to remind everybody then what happened in the third wave, around about the 20th of November, we saw a lot of increase in cases and admissions. It started going up. There were multiple communications around the 3 Cs. And then the variant was identified in December. Levels 3 restrictions late in December. And that then showed that all of this. So we have learned that actually there's lots of things that we can do to mitigate the, from the second wave that will help us to learn for the third wave. So if you take all of that together, we then say in between waves, there are clusters of cases. So you'll see the graphic in the middle. It really says that when we are in a wave, we try and prevent people from dying. So we provide hospital beds, oxygen, all of those things. When we're in between waves, we try and contain the spread, make sure that there's no new spread. When we're in the wave again, we mitigate that. We're trying to prevent that, get hospital beds, get oxygen so that people don't die. So now that we're going back into the in-between for the next 2 months, again, in between waves, our attention then shifts to clusters of cases that we're looking and we're sure, okay, in bars and restaurants that people don't spread, in workplaces. And we've now realized that funerals is a big driver of clusters. So it's be mindful that we know that the places where super spreader events can happen, that we really contain and limit outbreaks. So our approach then follows the following. If you want to say surveillance is the key mechanism that we now switch from containment to mitigation, the first question on top is how vulnerable are we for community transmission? So in the next 2 weeks, we will know, having taken blood from the people that presented for diabetes care across the province, we will know an updated seroprevalence per geographic area in the next 2 weeks. So that will tell us how vulnerable we are in which areas. And then, as the minister says, we can start predicting whether there is vulnerability in the different areas across the province. The second thing is the molecular surveillance. That is the scientists checking that the virus is not genetically changing. That is identifying new variants, keeping cognizant of it, and making sure that there's not an emergence of any new variants. That's the second thing. The third thing is the wastewater, and that is a system that we've implemented to see from the wastewater whether there's any evidence of COVID in the wastewater. So it's also an early sign. And then the bottom one is what we've been doing always, is to track cases, admission, and deaths. And it's really about checking how many new cases there are and to make sure that we can track what happens in all of this. So a combination of all of this is what we will be combined to do for the next 2 months. So at this point in time, we are suggesting that we have a 3-pronged surveillance strategy. On the left-hand side, that is the antibody studies that I told you about, and in 2 weeks' time, we'll know that. In the middle is the scientists continue to check whether we don't have new variants, and we continue to track the wastewater system to pick up any new signs. And on the third, right-hand side, for any new cluster of cases, we identify people with symptoms, we respond, and antigen testing is going to be the big one we're going to use in terms of that. So that is our strategy for the next 2 months. The prediction then is, as I go into the third wave, we are then developing a 5-point strategy to contain this. Firstly, behaviors. Secondly, surveillance and outbreak. Third, the mass vaccination program. Fourth, scaling up the health platform response. And fifth, keeping our staff safety, because our staff is the key component in terms of coping this. So what we're saying at this point in time is this is the strategy that we will embark upon for the next 2 months. And as the winter months come forward, we are currently preparing ourselves for a third wave, maybe equal to the size of the second wave initially, and then scale it down. But that is our preparedness we're putting in place, and that we are expecting it to reach us somewhere towards May, June, But if there's outbreaks earlier, we must guard against it not being sooner. So that's really what we are putting together. Now I'm going to share each of those specific ones. The prevention, the first one. It's important that we know that we can do things to contain the spread of COVID. So since the introduction of level 3 measures on the 28th of December, all our measures have declined rapidly, and we are now right down to where we were before the second wave, right? But we also know that there are very important things that we can do, and that's the hand washing and all the things that we've mentioned to contain the spread. When the president made his announcement on the restrictions, he then placed South Africa on alert level 1. The curfew is now from midnight to 4 a.m. The alcohol sales are now permitted as normal. Mask wearing is compulsory. Gatherings now 50% capacity, venue capacity to a maximum of 100 inside, 50% venue capacity to 250 outside. Health protocols have to be maintained. Stay away from closed or crowded places, the 3 C's, and encourage the use of the SA COVID Alert app. So those were the announcements about the current state of where we find ourselves. Now, community prevention. There's a study that's been done, NITSCRAM study, has shown only a 40% compliance with mask wearing, which is concerning to us. So already as we go into this, it means 60% of people are not really sticking to the mask. So we already have a challenge going into level 1 restrictions. COVID fatigue and the reduced vigilance is a setting which increases the risk for transmission. Even with vaccination, protection is not 100%, so you're still required to adhere to those protective measures. And then we require renewed efforts through messaging and social mobilization. Dr. Vallabji has spoken to the behavior experts during the course of the week, and they're going to help us with advice around behavior change during this period. If you go to surveillance and outbreak response, I think that's what we told you. We're in that intermediate stage between waves. And really the most important lesson from the previous 2 waves is that we adopt policies and strategies to ensure that we can do things rapidly and flexibly. And that's appropriate to the stage of where we find ourselves. So important is policies should not be wasteful of resources. They should either be directly contributing to disease control or withdrawn. It would be preferable to have policies clarified beforehand and implementation ready according to the trigger. So we should have pre-specified trigger points. At what point do we switch from one policy to the other so that we are agile in our response? So that's the biggest learning from wave 1 and wave 2. So testing. So PCR testing is very expensive. Antigen testing is much cheaper and provides rapid results. So the positive test cases that antigen test misses are those that are late in the infection, who are considerably less infectious. And so the impact on disease is not that severe. So throughout the epidemic, the department needs to be prepared to review the value of testing. And the value of testing at the hospital level is different as it relates to case management. So the antigen test is available within 15 minutes. So the implication for responding to the results at the same time as opposed to remote action via a call center. So it gives you ability to go in and say, yeah, you positive, you negative. So we can actually do that. So we're going to scale up antigen testing as the big drive for testing going into the 3rd wave. Offsite testing, there should be a place for offsite testing to try and control, recognize outbreaks. So if you go to an old age home, a prison, a school, it's better suited for antigen testing. So when we're at the site, we can do the rapid test right there while we're there. We don't have to wait for a laboratory. And we have an advisory committee that will continually advise us on the criteria and update us so that we have the best possible testing strategy to mitigate what we're facing with. Contact tracing and case management is still a very important thing, but you can understand that the case informed of results, that's the laboratory SMS, COVID Connect. Then the case management, we identify high-risk cases, provide info on danger signs, communicate with our teams, make sure that we assist with a range of things. And then contact tracing is to identify and advise close contacts to quarantine. It's useful for super spreader events to do backward contact tracing, and especially in the phase where we find ourselves now. Now, the lessons and innovations from the second wave is the vector program on diabetes worked extremely well. And that means we phone all diabetics and we make sure that they don't deteriorate and keep a tab on them. The pulse oximeter project has been groundbreaking. So our teams have given people that's at risk a pulse oximeter to take home so they can take the oxygen reading at home. And they can then know if the oxygen starts falling on the reading, that they can start coming back into the system. A real good monitoring system that we will leverage off for the third wave. Then a counseling collective was an excellent innovation that came out of one of our areas, in that they realized the impact of trauma and grief. And they started putting a counseling system in place for everyone, not just for healthcare workers, for families, for people that was struggling with family members dying and passing away. And then the last thing is the success of our provincial contact center. The provincial center was a phenomenal success in being able to contact people and stay on top of it. On contact tracing, when you have widespread community transmission, contact tracing started having limited value because literally everybody could be infected. During troughs, between waves, contact tracing is very important, and we should focus it on high-risk settings like old age homes, prisons, but also, as we said, super spreader events, so that we can quickly identify the contacts, make sure they're quarantined so we can stop the further spread. If you look at quarantine and isolation, Q&I facilities will continue to be provided for those who cannot do Q&I themselves. But there was limited utilization in wave 1 and 2 owing to a range of reasons, which is unlikely to change during the third wave. So the uptake for Q&I has been low. So 2.8% of lab diagnosed cases were in isolation over the pandemic. 4.3% in the first wave, 1.8% in the second wave. And the time between the date of test and the date of isolation was about 4 days and 4.7 days. So what we are promoting is an agile response in commissioning facilities, especially in the rural districts, to the emerging needs. Like during the second wave, this was done with us in Public Works in close consultation. So a structured mechanism for collaborating with Public Works and Health at the strategic and operational level was enable us to put quick, agile responses together. So we don't have a whole lot of empty Q&I sites. We bring a Q&I site on. As the need increases, we bring another one on site, another one. And as it starts emptying out, we start closing Q&I sites so that we are mindful of using resources wisely. The call center, we said, was a resounding success. And we are now proposing that the call center actually gets scaled up. And we will escalate the capacity in preparation for wave 3 and beyond. And the value streams of the call center, level 1, is they inform the person about the positive COVID result, advise them on the need to isolate for 10 days, identify all the close contacts, advise close contacts to quarantine. A level 2 is to assess the need for Q&I, refer so that the person can land up in Q&I if needed. Level 3 is to ask for medical well-being and to check, is there medical science, and refer for clinical escalation to doctors to make sure that people at clinical risk also is managed. So it's been a resounding success, and we really will upscale this capacity. Then the health platform capacity. The first big thing is on primary care is managing chronic diseases better. Member Mare has asked me this question over and over. We know that comorbidities are important risk factors for mortality for COVID. The Vector project that focuses on the proactive identification of diabetics specifically, and the close monitoring by a medical team and admission at the earliest sign of decompensation will all be scaled up. So we will have a special focus on diabetics, and we will build it into the way we manage diabetes way beyond COVID. The telemedicine call center capacity and the medical team capacity now needs to be increased, and then our chronic medicine delivery to patients will be sustained, and even other models are being explored, including pickup points, e-lockers, home delivery, a range of other things in terms of that. When it comes to intermediate care, it's proved invaluable during both peak periods. The ability that the first wave, everybody remembers CTICC. The second wave, we've had Brackengate, and then we brought the Mitchells Plain Intermediate Care Facility on board. And the point is we'll explore mechanisms to escalate and de-escalate capacity at very short notice. We have now successfully got the lease at Brackengate to be secured for another 3 years. So Brackengate is secured, and we can bring it online as we need. The staff are maintained on short contracts and will be used as an internal agency across the platform. What I mean by that is we brought 1,000 staff members online during COVID. We can now put them on short contracts and deploy them elsewhere in the system. And as they are needed for COVID, deploy them into the Bracken gates, into the intermediate care facilities. So now we have a neater system of deploying and redeploying our own staff. And the beds currently used for COVID could be used for broader intermediate care purposes that can relieve acute bed pressures in between periods of COVID. So we also then use the beds more smartly with the waves of COVID. If you go to the acute hospital, including critical care, its re-escalation to comprehensive service addressing backlogs will now be done in a much more incremental manner. We maybe were a little bit too fast after the first wave to go up with comprehensive services, and then we had to scale down very quickly. So we'll do it in a much more titrated manner. The trauma load has already escalated since the alcohol restrictions have been lifted. So we're making a big call for restrictions, appropriate restrictions and behavior change related to alcohol use. Then mechanisms to de-escalate service at short notice. We've learned from both waves. Agile mechanism like the daily huddles of clinicians, EMS managers to monitor bed status, to make quick decisions. Those things have been institutionalized. And we've got a fascinating and a very good provincial hospital bed dashboard, the bed bureau. It's a critical tool that's been developed to help us to keep a tab on where the beds are. Patient transport has been a critical enabler to move patients between facilities to distribute the workload. Efficient discharges and getting people out of facilities was important to create access for more ill patients. And then the private sector collaboration. We continue to build towards one system of universal health coverage in the long term. In the second wave, the private sector was diverting their patients to the public sector hospital. Thus, it's important for us to continue to work with the private sector to serve the total population. Other important lessons we learned was the proactive engagement with suppliers around oxygen supplies, the agile mechanism for the daily huddle to make quick decisions about oxygen, and it was really testimony to a whole lot of people that we never ran out of oxygen during the second wave. We've now got a dashboard in place to track consumption, and we've already replaced 2 or 3 of the places with older tanks already in preparation for the third wave. The data-led tracking to inform systems response in real time, the dashboards, the rollout of hectares to track trauma and ECs, the data has stood us in good stead and our dashboards has helped us. The communication and messaging, we've really built, and we are very committed to it, transparent sharing of information to build trust. Our public dashboards have now taken more than 2 million views already and has won international accolades and rewards as well, awards as well. Accountability, we take it very seriously that we keep cabinet and legislative structures like the ad hoc committee fully informed and regularly. Our agility and adaptability within the rules really is how we deal, and we are extremely proud to convey to you that we have just been told by the Auditor General that we've achieved a clean audit for 1920 during all of this COVID disruptions. Then the staffing that we've employed more than 1,000 staff. Thank you, sir. Employed more than 1,000 staff during the second wave, and we're now exploring that internal agency to maintain the staff on short-term contracts and to move them around as needed. When it comes to staff safety, just to give you a sense of what the impact was on our healthcare workers, we've previously shared this with you. As of this morning, there's only 42 active cases amongst healthcare workers now, but we know that at the peak we were at more than 1,000 active healthcare workers. The saddest part for us in the healthcare system is that we lost 120 healthcare workers across both waves. That's why the vaccination program is so important for the healthcare workers, because we want to track by giving healthcare workers vaccinations that we don't have a repeat of the infections and therefore the repeat of hospitalizations and then the repeat of deaths amongst healthcare workers. So our strategic framework for staff safety is that we have governance. Occupational health and safety is an important thing that we keep track on. We have now got a technical committee. We have local occupational health and safety committees. We just completed a National Institute of Occupational Health audit, and we know where we need to work to strengthen our occupational health and safety, and we do it with our organized labor colleagues. They've been incredible partners with us in terms of this. So the second part is the strengthening of OHS. We're looking at our policy. We have adequate supplies of PPE. We've procured OASIS from the National Institute of Occupational Health. It's a very good data system that keeps us up to track of where we are with occupational health. We also have a specialist network now that supports our services. And we're now busy addressing the findings of that national audit. Then communication and behavior change. It's really about personal protective behavior and key messaging to our staff in quarantine and isolation. And then the employee support. We pride ourselves on the face-to-face counseling that we offered our staff, the trauma and critical incident counseling, the psychosocial support interventions, the updated policies, the healthcare worker learning collaborative, and the fact that we've done a very intentional learning and healing and grieving process. So this intentional grieving and healing and recovery process, we've mentioned to you before, the impact has been massive on our staff, both frontline and support staff. Moral injury is a very real thing. It's the sheer scale of making life and death decisions daily. Young doctors, young nurses, specialists have to make decisions about who lives, who dies. It is devastating for somebody or for people working in the healthcare system whose primary aim is to heal and bring relief of suffering for everyone. Witnessing death, there's more than 10,500 deaths. It's now 11,000 deaths. But actually, if we think of each death has had tremendous impact on the family of where the person died. But another way to look at those deaths is many of those deaths, a healthcare worker had to witness without a family member of that person being present. The trauma that comes from that has been immense on our staff. The relentless service pressure. The second wave came in exactly the time where healthcare workers are supposed to take annual leave and recuperate and spend some time with their families. There was no Christmas, there was no New Year for healthcare workers in this province. The emotional anxiety and fear for themselves and their loved ones. The impact of being in quarantine and impact on the remaining staff. The loss of the 115 staff members, exhaustion, burnout, and grief. So we've started this intentional grieving, healing, and recovery. We've created structured safe spaces to connect with staff and leadership. We showed our vulnerability. We've cried together. We've expressed our grief. We've expressed our sadness together. We've allowing frontline and staff to speak their minds and for our leadership to listen. We slow down, we pause, we allow for healing and recovering. We pace the recovery, we pursue the next set of priorities, but all the way through we provide emotional and counseling support. In short, we've learned how to become kind and be kind to one another at all times. The vaccination program, Chairperson, I'm very mindful of the time. The vaccination program, just to talk about the J&J Sisonke program. It is limited doses that's been secured as part of the Sisonke program. That's the 300,000 to the 500,000 doses for the country that Minister Mbombo spoke about. It will come in 4 tranches. It is a expanded trial, clinical trial. It's not to check the effectiveness of the vaccine, but it's a trial for rollout, to learn how to roll out vaccines to others. The first tranche was received on the 17th of February. It was 13,160 doses. It was for private and public sector. And it is anticipated that we will cover only 40% of all healthcare workers over this 8-week period. And remember, the target is 132,000 in the province. The launch took place on the 17th of February, where President Ramaphosa and Minister Mkhize was amongst the first South Africans to receive the vaccine. But we're glad to say that the sister that was sitting there on the chair received it before the president and the minister. So she is officially the first person that received it in this country. Grootske and Tygerberg commenced vaccination on the same day, and Karl Bremer is also started it on the 23rd of February. So between the 17th and the 28th, we had the 4 sites. As of this week, Minister Mbombo has officially opened Malumed and Gatesville, and we're glad to say that George, Worcester, and Paul has now administered their first vaccines yesterday. So we have officially 7 sites. So the number of doses that is allocated is pro rata. So it is too few doses for all the people that need it. So what we've agreed to is to have a set of fairness rules. And that is, we do individual vulnerability by age, individual vulnerability by comorbidities, risk of exposure, and then the criticality of the setting. And we apply that in a fair way, that we do rural, metro. We do public sector, private sector. We do hospital-based staff, EMS, primary care staff, and community health workers. We do government, Western Cape government, and City of Cape Town. Western Cape government, City of Cape Town, and NPOs. So it's really about getting the fairness of how to do it across the various areas. I'm glad to show you this dashboard. This was the dashboard, the national dashboard, as of 6 o'clock last night. You will see that the Western Cape is the little purple bar. You know that we by far don't have the most healthcare workers in the country, but we have vaccinated the second most healthcare workers by 6 o'clock last night, of 14,368, only second to Gauteng, which was 19,567, and Gauteng has got significantly more healthcare workers than the Western Cape, followed by KZN, Northwest, Limpopo. Obviously, as the vaccines come in, we would like to move as fast as we can, and we believe we can vaccinate even more if we add more doses. So planning for phase 2 and phase 3. So the lessons, if we listen to the lessons from international experience, the lessons is 4 big things you can learn. High-level leadership and commitment is crucial. And that is leadership and commitment that can pull everybody together, not people bickering at one another, but everybody working together. Then the 3 big things that success is information systems. Is people have appointment systems, they can be monitored, they can be reported, like the dashboard I just showed you now. Every day you can see how many people are vaccinated. Also effective communication and getting the citizens engaged so that they can trust and they can buy in from the citizens. And then very highly organized and efficient logistics. If you put these 4 things together, you will be successful in doing your vaccination program. So this is the global vaccination coverage as of the 26th. This is per 100 people. So you can see that Israel, far and above everybody else, has administered 91 per 100 people. Almost 91% of the population has been vaccinated already, followed by the United Arab Emirates, which is close to 60%, followed by the United Kingdom, which is just less than 30%, and the United States, 20%, Serbia, 20%, and so the other countries. Obviously, we are competing against these countries that have had, let's call it, pre-access to vaccines. And that's part of our challenge to get access to vaccines, because all these countries have got vaccines. So we have 4 considerations then for the second wave. There's an urgency, and the urgency is born by the fact that we want to maximize vaccination for priority groups in the next 3 months to preempt and mitigate the impact of the third wave. So while phase 2, we will not get herd immunity, but if we get any vaccines in April or May, it would be important for us to get to the most vulnerable people first, so that we can mitigate the people that would get ill in the third wave and mitigate the impact of the third wave. There's also that we need to have an efficient delivery system. So I've just shown you we can vaccinate, but we need to scale to much higher numbers and quickly. And given the limitation of vaccine availability, the contingency plans to procure additional vaccines in support of the national program and for the province is what we are busy with. And then prioritization and sequencing for phase 2 will then need to be refined. Because you can imagine phase 2 is 2 million people. And we're going to have to say, if we don't have 2 million doses, who goes first in phase 2? And, you know, kind of how do we actually make those kind of decisions? So on sequencing and prioritization, so the preliminary thinking from the Ministerial Advisory Committee on vaccines is that you should have strategic principles that guides how you prioritize for phase 2. So you want to minimize deaths. You want to minimize life years lost. You want to minimize infections, and you want to minimize economic impact. If that's what you're guided with, you want to move from essential workers to maybe say workers at risk or workers that are crucial to the functioning of society. Clinical and exposure risk to be combined into a composite score. Granularity and stratification should be weighed against feasibility, and an approach to prioritization may differ based on the implementation model. But if you put all of that together, it would mean that we would prioritize, for instance, the elderly in this province, because we can, and people with diabetes, because we will get the greatest impact because we know they're the most vulnerable when we go into a third wave. And this is examples of it. So if we have limited doses, maybe we should vaccinate everybody over the age of 70, or a combination of people between 60 and 90, plus diabetes and 3 comorbidities. And the more doses you have, the more you add people. So that would be the approach that we recommend, and we will obviously consult that widely in the province. So we've got this governance arrangement then. We've just established now a Western Cape COVID-19 vaccine rollout steering committee. I'm the chairperson and convener. We had our first meeting in this week. We are connected. I'm a member of the National Vaccine Coordinating Committee, and we want to establish wide stakeholder forums that comes out of the steering committee. Internally, we then have a coordinating committee with a project office, and we're going to focus on those 3 big things: the operations and logistics, the information systems, and social mobilization. This is the steering committee composition. You can see I'm there, supported by the important senior managers in our department. The IEC is probably the one entity that has got the most experience in doing things at scale. So we have an IEC representative, and we're learning a lot from their experience. The City of Cape Town and the district municipalities are represented. The business sector is represented. The private health sector is represented. And then we have local government, Department of the Premier and Treasury represented. But we've also invited faith-based leaders representation, organized labor, and somehow the last bullet has fallen off, and that is civil society. We also have a rep from civil society on the steering committee. We had our first meeting, very exciting meeting. Everybody is committed, and we will work together to achieve this for the province. So this is just some last thoughts of social mobilization. A key thing to do, we need to mobilize and tap into existing networks and resources. And really, people from every community should feel that they want to have a vaccine. So it's important that we tap in with all formations in society to mobilize people to become part of this. The logistics, the service delivery platform will include public and private health sector, so mobile skirmish farm. We might have to create, and we will create, temporary high volume mass vaccination centers, also workplace a way of doing it. The implementation model is if we get vaccinators per day. So I showed you what happens, and I can show you what happens in other countries, but we think in this province, we should be able and aim for being able to do as high as 25 to 30,000 vaccines per day. So if we can think of that, how do we get to do 25,000 vaccinations per day? That's the kind of scale we have to think, and then prepare the number of sites and high volume sites to be able to say we will reach that target. And the information system is crucial, and everybody is working on the national information system. The dashboard I showed you is drawn from that national dashboard. It's working, and it's the place that everybody will work together. The geographic models, we're going to pull all of this together in one geographic area. And just to show you a little bit of, I showed you about the UK and about Israel. Just to tell you a little bit about how the UK has done it. You can see in the UK, they're doing 450,000 vaccinations per day. Israel peaked 180,000 vaccinations per day on a 6-week program. So you can see the vaccination sites in the UK. There was 206 hospital hubs. There was 1,200 local vaccination sites, but they also have 50 big vaccination centers, like sports stadiums, hotels, cathedrals, all of those. The key success factors in Israel: strong infrastructure, single record, 4 big health agencies that drove it, but they also got these, what they call vaccine compounds across the country, drive-through, pop-ups, all kinds of things. And they have a chain of things, and they could be able to do quite big volumes. So we can learn from those experiences in the volumes that we can throughput once we have the vaccines. So the potential for South Africa should be, we should aim for 250 to 300,000 vaccinations per day. That's a very steep target for the country. We're saying in this province, we should aim between 25 and 30,000 per day, because we roughly should be a tenth of the population in this 10% of the country. So in concluding remarks, we've learned very valuable lessons during both waves for COVID-19. We will refine them, we'll apply them, but we'll apply for our third wave preparation. Our community prevention measure and adherence to non-protective interventions must continue to emphasize. Hand washing, social distancing, the 3 C's, and making sure that we wear the mask. Require vigilance and surveillance to pick up any signs, and we will do that. The health platform preparedness will be agile, so that we know what to do, how to bring it online, oxygen, staff, PPE, all of those things, we'll bring it online. Our budgetary provision is now being made so that we can meet the resurgence response. The Treasury has confirmed our budget allocation. For the vaccine rollout, we will assume that we will get an adequate supply of effective vaccine. We then need to sequence and prioritize, as we are unlikely to receive all the stock in one tranche. So we'll get the stock in different tranches, but we need to be able to be geared up to deliver as they come. Focus is on readiness as a province to get jabs in arms in the shortest possible time. 3 main pillars: social mobilization, the logistics, and a smart information system. So the last thing we want to say, this is not a Western Cape government health responsibility alone. We need the united effort across government, business, organized labor, and civil society. This is a huge opportunity to strengthen the relationships, build solidarity, create innovative service models, and in a sense, rewire ways of doing business across sectors and pooling resources where possible. Consolidated and coordinated project management support is required. The mechanics is what we will sort out in that steering committee. And there's an urgency to start preparation in earnest. We just want to share humbly with you, this is our preliminary thinking. It will be tweaked, but we will keep this committee informed. Thank you very much, Chairperson.
Thank you very much, Dr. Christie, and congratulations on your audit outcomes. That's very good news. Well done. I'm sure there are a number of questions, so I'm going to hand over to the members now. We'll work it in our usual way, where I'll give each party, political party represented 3 minutes to pose their question. We'll go through all the parties, and then we'll have responses, and then we'll go through to a second round if there are more questions. So as usual, I'm going to start with the DA. Are there any questions from the DA, please?
Yes, Chairperson.
Thank you, Honourable Philander. Please proceed.
Thank you, Chair. And from my side, also a huge congratulations to the department on the audit outcomes. Chairperson, thank you, Dr. Noma French, Dr. Klute, and Dr. Valabji. Chairperson, Dr. Klute made mention in the presentation of the potential risk factors, the containment and mitigation strategy. It is alarming to hear that residents are not sticking to the basics, and one should really realize by now that government cannot do this alone. Chairperson, I want to ask, in terms of the quantities of vaccines or the dosages that we currently have, is that quantities, is it sufficient for the entire phase 1 trial rollout? And also, Chairperson, how is the department managing those quantities in this first phase with a looming third wave, Chairperson? And also, by when do we expect more vaccines, and will that actually supplement or complement from what we receive, by when we receive it, in terms to successfully roll out phase 1?
Are those all your questions, Honourable Philander?
Yes, Chair.
Thank you. Then if I could just use the remaining time, I'd like to ask, in the previous briefing that we had at this ad hoc committee, we learned that there was supposed to be 117,000 Pfizer vaccines that were supposed to arrive in February. I'd like to understand, did those Pfizer vaccines arrive in February? And if not, are they still, is it still a plan for us to get those Pfizer vaccines into South Africa? Then my next question is, will GPs be participating in phase 2 and 3 and assisting the department in rolling out vaccines? This is a question from constituents. I'd also then like to ask whether False Bay Hospital will become a vaccination site, whether that information is available at this stage. And then my final question is, I've been doing a lot of reading about the Brazil variant, which is raising a bit of alarm around the world. I'd like to understand, has the Brazil variant been identified here in the Western Cape yet? And those are the questions. Thank you. I'll then hand over to the ANC. Are there any questions from the ANC, please?
Yes, Chairperson. Thank you, Chair. Laat my toe om eers vir Dr Christie terug te verwelkom. Dok, ek het probeer om u nie lastig te val gedurende u vakansie nie. Ek het dit amper reg gekry, but nevertheless, Chairperson, I welcome the report, the presentation from the Department of Health. With regards to the civilian strategy, I want to understand the backlog in the testing labs. Perhaps I missed that part. And then, Chair, with regards to the community prevention that was mentioned, I want to highlight the plight of farm workers who are on a daily basis traveling to work at the back of trucks, where there is no possibility of social distancing and at times no wearing of masks. What is the government doing about this crisis? And also communities who are without water for long periods and still are without water at this moment. Why I'm mentioning it? Because I think it was mentioned previously that the Department of Health can't do it alone. And that's why I'm calling for that intergovernmental approach from our senior, let's say from our department to bring in the other departments. Then, Chair, if we can then move to, I think it was on slide 42 with regards to the vaccine rollout. Can you give an indication of the mood of health workers regarding the vaccine, and then how many are reluctant of taking it and how many have registered for it? Then I want to know why only one private hospital is added to the list. What about the others? And in the old presentation, there was a slide, I think it was slide 44, showing low vaccination numbers for KDH when compared to other facilities. Can you provide clarity on those low numbers and why no vaccination took place on several days as reflected in that presentation? Thank you, Chair.
Thank you, Honourable Windvogel. I'll then recognise the EFF. Honourable Plejo, do you have any questions?
Yes, thank you, Chairperson. My first question would be on slide 33 on the issue of acute hospital, including critical care. The second bulletin highlights that the trauma load has escalated since the lifting of the alcohol restrictions. I would like to understand from the department that what kind of advice would you give government, citing that there might be a possible third wave that is coming, as far as to the issue of alcohol restrictions is concerned. And then secondly, is that the issue of slide 37 that talks about the strategic framework for safety of staff. I've noted that you say there is regular engagement with the organized labor, noting that there is currently wage negotiations that are taking place and the morale of workers is grossly down. So now I wanted to understand that in terms of that in the engagements that you are having with the organized labor, is there no possible threat of maybe unrest or strikes that might take place during critical time? And then lastly, on the issue of targets, I see the estimate, or slide 42, that the estimated target is 40% of healthcare workers. That how possible is it if areas such as the Central Karoo do not have the vaccination facilities. So I just wanted to understand that why would the likes of Central Karoo, who recently served as one of the hotspot areas, do not have any vaccination facilities? Thanks very much, Chair.
Thank you, Honourable Trejo. I'll now recognise the Freedom Front Plus. Honourable Murray, do you have any questions?
Yes, thank you so much, Speaker. I just want to switch on my camera here. Yes, something that struck with Dr. Christie is how you intend vaccinating people, in which order they will be vaccinated. And I see you say old age homes, first the health workers, okay, and then old age homes, and then prisoners, then those over 60, and those with commodities, and then the over 16-year-olds. Now, then my brain just lit up, and I said, who are the major spreaders of this COVID? Is it the people in old age homes? It's certainly not. They don't go to dances and clubs or watch soccer or dance till morning. It's the young people. They are the spreaders of all this because they like clubs and bars, restaurants, soccer matches. Shouldn't they be getting it first if you want to contain the spread of the virus? Shouldn't we make it a condition, the national minister that constantly pass new regulations? Has she ever thought of saying attending clubs and all that is conditional on the people that is going to be there being prepared to take the shot? Then we can review the situation and come down to level 1. So I'm asking you, do you think that perhaps we're taking it at the wrong end here? We first give it to the old people who are sitting there in their wheelchairs in an old age home, instead of to the young people who run around the city spreading the virus. And then I would like to know, how soon after being vaccinated are people most likely to acquire immunity? Thirdly, how soon will people get the results if they go for testing for this COVID? How prepared are we? How are we get? And it must they wait a few weeks, few days, a few months? Did the National Council, Command Council, take on board any Western Cape proposals with how they should contain this? Or are these ideas all ideas that emanate from the National Minister? And then did you have any discussions in the Western Cape with the private sector to assist you, especially with logistics? Because it's going to be quite a big task. Logistics is going to be one of your big headaches in reaching people, in moving of the vaccine, and also of opening up places where people can go to be vaccinated.
Thank you.
And then the third, sorry, my 3 minutes is up. Okay.
It is, but you will have another opportunity. Thank you, Honourable Murray. Thank you, members, for those questions. I'll hand over straight away to the Minister and the HOD to respond to those questions. Thank you.
I will start, Chair, and then some others Dr. Christie can add. In regard to the quantities of the rollout, it's a question from Member Philanda and also related to the phase 1. As I indicated earlier in my opening, this is part of the implementation study using the 500,000 doses that South Africa received from the J&J, which were initially leftovers from their 3A phase of their trials studies. So whilst the South African government has envisaged to vaccinate 1.2 million, if you recall, from the AstraZeneca in terms of their accounting, and also for the Western Cape, it's 132,000 out of that 1.2 million. The doses that the South African government will be receiving for this phase 1 for now is the 500,000. And then within those, depending, because it's only for the healthcare workers, depending on the number of health workers in the province, each province gets an allocation in every second week. So we started to have about 13,160 from the 17th of Feb, and then now it's gonna more or less the same amount, which initially they divided it accordingly because we have extended other sites, like for example in George, where actually the plane can just provide, drop the vaccines there directly to George. So that's where we are. So therefore, it means that when we receive as a country any other doses, which is, as I indicated earlier, the president confirmed the 11 million, it means that we have to firstly finish up the healthcare workers that will have been missed from the 500,000. So that's where things are in regard to the rollout. Again, remember, it's part of the implementation study. In similar with the issue related to the phase 2 or any other drugs, we still work within the national program. So if the national, like as I indicated, if the national, whether it's a presidency or the national health minister makes a promise and say that we will be receiving, we hear that information just like anybody else. So if at the time they indicated that we'll be receiving about 170,000 Pfizer in Feb, that's what they said. It's not us who are saying, because we won't know unless they tell us. But with the presentation that they did in Parliament, National Assembly, and also even in the NCOP, and also within their pressers, what we saw was about the 1.5 million initially for AstraZeneca, which was going to be split, and then 500,000 later. And then we find that they were expecting also the COVAX, 150,000 times 3 pay each month. And within the COVAX, for the COVAX, it wasn't determined what type of vaccines that we're going to get from the COVAX. So we don't know whether it's going to be Pfizer or whatever. But in the last presentation they did, the Pfizer that is reflected there, it's in May. So if things change today or tomorrow, we have to move with the flow in regard to what they are saying. In regard to the GPs, again, remember with the COVID, it has always been the approach, one tier system, one health system in South Africa. And in the province, we as the province, we see as a provincial health department as a steward for any other pathways in regard to access healthcare services. Be it it's a private health, be it it's a complementary medicine, be it with whoever, whether it's a civil society. Therefore, it's just like when we were working out on the critical care beds, we added the critical care beds from the private when we were counting them, although we didn't use them. So similar, we do have an expectation, and as already we have done, because we did present one time our rollout vaccine plan, where we showed that we have got 378 sites for vaccination for public and 41 sites for the private. For that, it includes whether it is in the clinics or whether in the GP or whether in the private health. So we do anticipate that we're still going to work together with any of, be it GPs or be it in private health, specifically in phase 2 and 3. The vaccination sites, because it also links up to what member Marie was asking. Again, because it is part of the study, in the initial part of it was to use the existing sites, research sites that were being used by the J&J. At the time, in their own research, there were about 21 sites. And then when now it became part of the country in terms of the implementation study, they identify about 18 sites, specifically hospitals. And then they did the allocation of the vaccines, which we ended up getting 13,160, where they said now the sites for Western Cape initial sites is Tigerberg and also Grotesque initially, and similar where they'll say in KZN it's Grey Hospital or Albert Lutuli and so forth. So that's what, because you have to have an access to the researchers. How it works is about where the pharmacists must make it a point, they are researchers as pharmacists, they use the same amount of dose. That's when they withdraw from the vial to the syringe and then give it to our vaccinators, because it's part of the implementation. You don't want a situation where some others might be given 0.5, others 0.3, others 1, because they still have to be followed up so that you see that things are happening accordingly as part of the rigor of the research. So that's why we rely on the sites being accredited, where the national will say, now we're expanding, and then they give us go ahead. So that's why the Kailua was added, Kalbrima was added, Mitchell's Plain is going to be activated, and also for the rural, the George, the Worcester, and also the Pearl Hospital. The Gatesville was approved by the National Department of Health to become the sites in the metro for the private health. As you may be aware that we have been, they've been coming to us over the weekends for the private health. So it is them who identify, or us, where we say we will be ready for such. As part of the planning, we will want to, in our third tranche, to extend it to the Vescas and also parts of the Central Karoo. So it's part of the process. Noting again, it's part of implementation study. The researchers must have an access to all of those sites. Testing generally, Dr. Christie can add there. Remember, we are where there's a high level of community transmission, whether people haven't tested yet, the sewage or the water testing does show that. With the antibodies, it does show that there are levels of, there have been levels of people who have been affected and infected. Therefore, when you ask about testing, when you're going to go to test, what we want to achieve when you go to be tested, it's different, we say, because we'll be traveling internationally. It's different, we say that I am diabetic and also 60-year-olds, just in case, because I've seen that I've got this flu and all of those. Or my daughter, wherever my bundle has been positive, and also I'm worried about myself, so that we could be able to prevent the severe illnesses or even deaths. But if you are just a 24-year-old, you are worried that you want to be tested, you don't even have symptoms and all of those. So what is the rationale for that? So we need to balance in regard that, what is the rationale for being tested, and also going also in regards to, just to add to the information about why are we targeting older persons when it's the bundles of joys who are the spreaders. Remember, even that we start with the healthcare workers. It's about where we don't want the health system to collapse when people come to the health services, and then you've got these healthcare workers who might have to take 10 days for isolation for the quarantine, or others even die. So with the vaccines, it means that we could still strengthen our health system where the chances of them being positive, or even if they become positive, the chances of being severely ill where the health system can collapse. That is the reason for the vaccination, but it doesn't mean the people outside there, especially that there is no indication when the phase 2 vaccination is going to happen, it means that they're still going to be spreaders. But the deaths and the severe illness, the people who ended up where they put more burden on the health system, as Dr. Casey has indicated, is those people who have got diabetes, because diabetes and the COVID, those two twins, it's when they drive people in terms of the severe illnesses, and the people that who ended up occupying our critical spaces and all of those. The older persons are the ones that will die when they've got the COVID. Therefore, we want to make sure that prevention of the severe illnesses and also the death, targeting the at-risk behavior. Hence, he was even indicating that even for the phase 2, do we have that excitement that let's vaccinate all the essential workers, the teachers, and all of those, because they're the essential workers. And yet we have got many other people where you could be able to prevent the deaths for them, as I indicated earlier, the vulnerability, the age, the criticality, and also especially healthcare workers, the patient facing. That one is crucial. Member Van Vogel indeed that it needs a whole of societal approach. And also we do acknowledge that the issue on the social determinants of health, like the water, sanitation, the sewerage, the poverty, access to nutrition, and all of those, these are the ones that needs to be in place, because we cannot just keep on mopping the floor for some of the illnesses that will have been prevented by other sectors and other systems, and also by other spheres of government to play their role. So the water availability, yes, the Swellendam, if it's in Swellendam or wherever it is, as you know that it is a core function of a municipality that has to be dealt with. And we can do as much as we can raise as many issues, but it needs everyone else to do their role. So that people don't have water, that has to be raised within that municipality. About the reluctance and the hesitancy related to the vaccine rollout, as you can see in terms of the numbers, we finish our doses actually quite quick in the Western Cape. And also, although Gauteng in terms of the numbers might seem that they've got a higher intake, but remember, it's in proportion to the number of the healthcare workers. They've been given most allocation. Actually, Baragwanath Hospital, Chris Hani Baragwanath Hospital has got the largest allocation, followed by the Tygerberg. So it's about the number of health workers in that place. Noting, when you say the allocation like Tygerberg or Proteski, it doesn't mean it's only for those staff. It means that it's also like a GSH for the Metro West, which has to accommodate even primary healthcare workers who are at risk in that feeder area, plus also the EMS, plus also the GPs and also the private. Similar with the Tygerberg, that is to accommodate such. Initially, we set ourselves a target where we said 500 vaccinations that needs to happen per day per each GSH and also TBH, and 100 per day for the KDH. So you can understand why KDH has got lesser numbers, because it only accommodates the healthcare workers more or less in that area. So compared to the others, two other hospitals in the metro that can accommodate more. Noting when we started in KDH, we started when we even were open there. I mean, we launched with the president, the national minister. We were using their facilities, which is, you know, that the KDH is always full. So it means that you have to pause and look for another venue because it was getting hectic. So we're not expecting KDH to be quite more, because it only caters mostly that side. Similar, when we activate Mitchell's Plain, it might not necessarily be taking the whole of the metro, might taking the Mitchell's Plain, plus also probably the other areas adjacent to Mitchell's Plain, like the Philippi. So it will depend then. I think the similar member, when you ask about the Central Karoo, one has to look in terms of the access in regard to the researchers. But from our side, we have already identified that in the third tranche, when we receive it, we will be taking care of Central Karoo and also the Vescas. In regard to the staff safety, I think the HOD can explain further around that. Similar also about the critical care and acute bed in terms of lifting of the alcohol. Also remember, in regard to our, as a province, the whole issue related to the district, to the Disaster Management Act and its regulations, it sits with the national, not with the province. So when the president has lifted up the alcohol and all of those, it's based on that, where you have to balance the livelihoods and all of those. And I indicated even earlier then, it also needs other sectors. So if you know that you've got dysfunctional families as a result of the alcohol abuse, or the people who are likely to be abusing alcohol and end up being injuries and all of those. So it's not only health that has to make sure that these issues are getting tackled and should be tackled. It must be everyone else, because as we know, alcohol is a societal problem. It's not a health problem. I think I've responded on the old age homes, the testing, also in regard to whether the National Council, Command, they do take some of the proposals. Yes, there are engagements at various levels, whether it's through the National Health Council, for example. In some instances, it's when the National Health Council urgently have to meet before the National Health Minister has to go and present to the National Command. Or sometimes it might be like a weekly basis where the HODs, together with the National DGs of Health, they meet and come up with some strategies. So it has always been like that. With the logistics about the private sector and all of those, yes, indeed, as I indicated earlier, we have always been one throughout. We have never, there's never been any binaries when it comes to the private. And some might recall that even before we had our first case, because I get reminded now that 2nd March 2020, that's when we shared our Western Cape readiness and response preparedness in regard to the COVID. Even immediately after that, I met with all the private groups where I ended up actually relieving some of the regulation, binding regulations related to the licensing and some of the section there, so that the private cannot be constrained in regard to getting more beds, specifically critical beds for us. So the journey with the private, it has always been there. And as I indicated earlier, that there are 41 other sites that we have added to the 378 in regard to the Western Cape rollout for the vaccination. At the time we were planning for AstraZeneca, it is all inclusive with all of them. Thank you, Dr. Casey. If you can add.
Thank you, Minister. You've covered most of it. I will just add one or two small ones. Just to indicate to the chairperson that when we have all the vaccination sites for phase 2, the 378 vaccination sites that we planned includes Falls Bay Hospital. There's been no pickup from the scientists of a variance other than the one that we have, 501 V2. We've not got any documented proof from that they've picked up any other variants in our setting. In terms of the questions about backlog in labs, there is no backlog in lab. In fact, when we moved out of the second wave, we currently have criteria that everybody that is symptomatic can be tested. They are tested and the results come back. So there's no backlog in labs. The issue about the farm workers and the trucks and the water, the whole of government response is actually coordinated via the district disaster management centers. Each district has got a joint operations center, and it is via the local authority. They bring all the various government departments together. So all government departments are supposed to do it. There's a provincial joint operations center and there's a district joint operations center, and they should bring agriculture, economic development, all of those people in there, and also the Department of Labor in terms of where labor practices have been exceeded. Just the issue about the uptake amongst healthcare workers. When we last reported to you, we said 53% of healthcare workers before the Covishield, that's before the AstraZeneca, indicated they will take the vaccine. 29 to 30% said they still think about it, and 20% they won't take it. We have taken a survey now after we've started the vaccination. More than 83% of healthcare workers want to take the vaccination. So it just shows you the moment you start the vaccination, people are starting to say, I've taken the vaccination. That whole hesitancy to take the vaccine has disappeared amongst healthcare workers. The other reason for KDH, ministers already explained, is because they move site, and also they don't do over weekends. And that is the reason why the numbers that we had on the cumulative graph is low. But as the minister said, there's also lower numbers given to KDH. Then in Member Klego's questions, in terms of alcohol restrictions, Member Klego, we definitely have recommendations. From a healthcare perspective, we do believe that there are some restrictions that should be placed on the sale of alcohol, and we are advising that some of those restrictions be implemented. We also are advising that localized interventions are required to increase policing and enforcement in terms of the areas where alcohol is freely available, resulting in the disproportionate trauma in certain areas. So there are specific recommendations, and we are tabling that at the appropriate places. In terms of our engagement with organized labor, I can report that we have an extremely progressive and helpful relationship with organized labor. Insofar, even with the vaccines, we've had 2 massive sessions with all the shop stewards in this province in full support of the vaccination program. So our engagement is productive, it is open, it's clear, it's transparent. In those engagements, when the issues of salary negotiations come up, our organized labor partners realize that that is a chamber issue, it's a central issue. It's not for negotiation at provincial level around the salaries, but our relationship is very, very progressive and productive, and we have no indication from our labor colleagues that there will be threat for unrest. In terms of, Minister explained that when we do a next tranche of these limited vaccines, as you rightfully say, we're only going to cover 40% of healthcare workers. We will make sure that we have access into geographic areas. So from George, the next tranche is to get at least Central Karoo and 1 or 2 other places. From Paarl, at least up the West Coast. From Worcester, at least into Overberg. That we have some kind of geographic spread for the next tranche of vaccines that will be arriving. And then I think the question was answered to Member Marais. The reason why we start with the older people, Mr. Marais, is they are the ones more vulnerable to get severe illness, and they're the ones that's going to come to the healthcare facility. So that's how we're starting. The issue about young people spreading it, that is true, but the only way you're going to stop spread is if you can cover everybody. So we're not going to be able to cover everybody. If you have limited doses, you're then protecting the people that's most at the risk of getting illness. And then the COVID test, as I said, the testing is being done everywhere. The rapid test, which is the antigen test that we're proposing we're going into now, your result is given to you within 15 minutes. So that's the result of the rapid test now. And then, as Minister said, a lot of our proposals have been incorporated from the Western Cape, and we are working very hard with the private sector for a big scale out for phase 2. Thank you very much, Chairperson.
Thank you kindly to both the Minister and the HOD. I did understand that there were a few more questions that members wanted to pose, so we will go into a round 2 now. Perhaps we could limit those questions to 2 minutes. I'm going to start with the DA. Are there any questions from the DA?
Yes, thank you, Chairperson. Chairperson, I just wanted to get, I received a social media request from the South African Offshore Workers Association, and they wanted to find out, because a lot of them are from South Africa, where do they fit in the vaccine drive, and who can they contact to find out when, where, and how they can get it, because they work in respective, or they're from respective provinces in South Africa. And then that'll be my only question this round. Thank you. I'll hand over to my colleague, Andricus.
Thank you. Honourable van der Westhuizen.
Yes, thank you, Chair, and good afternoon. I've had a request from elderly people on medical aid who are quite anxious to start early in the queue for vaccinations. How and when can they register? Will they have to register online through a similar portal as the healthcare workers have registered? How will this portal be utilized? Are you going to go straight to old age homes and then vaccinate all the elderly there, or are you going to work with individual cases where people must register and get onto a list, etc.? And then also, Chairperson, can I just ask as to the cost of the vaccinations? I trust that many of the healthcare workers, being public servants, are already members of medical aid. Are you charging that as an expense against the medical aid of those workers? And what is this the cost that you invoice the medical aids for these vaccines, especially since it seems to me some of them have vastly different prices? Thank you.
Thank you, Honourable van der Westhuizen. Perfectly timed, just exactly 2 minutes. I'll now hand over to the ANC. Are there any questions from the ANC?
Yes, Chairperson. Chairperson, mine is on the Western Cape planning to move away from PCR testing to antigen testing, even though it is not 100% accurate. And has this been raised with the Command Council? And what is the cost difference between the two tests, and where will province get these tests? Then, Chairperson, what caused the limited utilization of quarantine and isolation facilities? How many of these facilities remain open today? Then my last one, Chair, kindly can department kindly give us updates on the Western Cape vaccine procurement process? Which companies are being engaged? What kind of vaccines are we looking at? And what commitments have been made? And what is the provincial budget for it? And where will it be taken from? Thank you, Chairperson.
Thank you, Honourable Windvogel. I'll then move on to the EFF. Are there any questions from the EFF?
Yes, Chair, I've only got one question. It's also based on slide 42 on the prioritization of phase 1. I see there that there is a list of healthcare workers that are identified to be one of the list. So the issue of the traditional healers, I just wanted to understand that how is a cooperation, because this is a sector or a sphere where there is no proper coordination of things, and yet they deal with a number of people in our society as far as assisting them with their health conditions. So I wanted to understand that how is that process going to be rolled out in ensuring that traditional healers are part and parcel of the vaccination process.
Thank you. And last but certainly not least, Freedom Front Plus, Honourable Murray, do you have any final questions?
Yes, thank you, Chair. I'm a bit confused by the department. Remember last time when I suggested J&J, we were told that National says J&J can't deliver. Locally produced vaccines is not preferred because they don't have the capacity to deliver the vaccine on time, even though they were cheaper. Now, all of a sudden, we intend vaccinating 11 million people with the same J&J as the supplier, but we are supposed to believe they will be able to meet the targets. So I don't believe anything coming from National in the first place. Maybe I just want the assurance that the department believe them. Then the second thing, Dr. Christie, you said immunity has likely increased after the second wave. That's good news. So why should I fear the third wave? Immunity will then increase after the second wave. Or am I wrong in assuming that once you've got vaccinated, it could develop into immunity for all the different phases that will follow? Can I just have a comment on that? And thirdly, you say that trauma load has escalated since we moved to level 1. So I know that you would have objected to level 1. And I asked the question, do they listen to the Western Cape? Certainly they didn't listen to the Western Cape. We are in level 1. We have an escalation in trauma cases. We have an overload of people coming and occupying trauma beds instead of us being able to give it to COVID patients. What is your comment on that? Are we happy with level 1? Can we manage the extra load in a trauma section? Or do you have a plan B where you have a deal with the private hospitals to accommodate the overflow? Thank you.
Thank you, Honourable Murray. Are there any other final questions then from other members? I think we're good. All right, thank you very much. I'll hand over to the Minister and the HOD for responses.
Thank you, members. I was just asking Member Mackenzie, because I couldn't pick up exactly what was the question related to the international South Africans, because they still have to meet the criteria and the requirements. If, for example, they are supposed to be vaccinated in phase 2 and they are here, it means that they'll be vaccinated accordingly. So if you are 60 or 70, or you meet the criteria, or if you are 18 or 20, you don't meet the criteria, we have to wait for the phase 3. So I wasn't sure exactly what was the question related to that. In regard to, I think, remember, who asked about Van about the elderly and the medical aid. There is no exchange of monies at the site of the vaccination. Because it's a national program, already when people, and it's for healthcare workers, it's the people who register in the electronic, in the data system, and then that person gets informed in terms of, the approval that this is your voucher number and where will the site you're going to go to. When you arrive at the site, the computer system that is there, where someone will take that SMS, that voucher number, and punch it in, and then we'll ask you further questions related to any symptoms, if you have been positive, plus also requesting your medical aid number. Or even they can make it easy to follow up with your ID if that person is on PESAL. So in terms of what is happening in regard to the claim that goes to the medical aid, how much, we are not part of that program. It's happening elsewhere among the medical schemes and the National Department of Health. Similar in regard to the cost, we don't know about the cost. We are not involved in that. It's things that are happening there behind the scenes among the agreement between the medical schemes and also the Department of Health. So we are not charging anyone for access to the vaccines. And it was actually confirmed by the National Health Minister even then, even for the phase 2, phase 3, the vaccinations will be free. And now what we heard from the National Minister of Finance, that they've budgeted, I think, about 9 to 20 billion, depending on the vaccination, plus also compensation fund and all of those. And also they are not increasing the taxes. So at this stage, in regard to the national program, there is no exchange of monies. And also for the province, we are receiving those vaccines for free for now, but we still have to be responsible for the consumables and the ancillaries, because you still have to have the syringes and the needles and all of those that you'll need to purchase for us, especially when there's a main rollout, especially for phase 2, where we anticipate about 3 million that we might have to vaccinate for the phase 2. A question about moving from PCR to antigen. I think what Dr. Christie was trying to explain is specifically for those patients or persons under investigation, where you just want to know whether the person does have, which is similar with the international travelers, where you have to be tested for the antigen. In terms of when it says that no, no, it means or yes, and then that's when you can be able to know that whether you should continue, go ahead for the PCR test. So it's not diagnostic. It's about where, especially in the hospital, where at least you know where to refer the patient to, especially when they come in, and then you want to know whether this person has had antibodies or has been exposed or not. So it's indeed for antigen testing, it's not for diagnostic purposes. So when now a clinician has to make a diagnosis based on whether the antigen is positive or not, and then that's when now they would continue with the PCR. So you must understand the difference, because most people, it's about, I want to know whether I've been exposed or not, or I've had, because when we do not have any of those, it means that that's when now you know the person hasn't been exposed. I don't think for now we'll be able to respond on what are the costs of the in terms of the quarantine and on how many, because there were only 2 items for us to respond to. It was about the third wave, preparedness, readiness, and also about the vaccine rollout. So probably if the HOD does have the answer related about the cost and also how many quarantine facilities are available now, he can answer, but I didn't prepare for that part. In regard to the vaccine procurement and also in regard to the commitment, the budgeting and all of those, we responded to that question before. Again, I just want to highlight that at this stage in South Africa, there is no vaccine that has been approved except for the J&J that got emergency approval, but within the clinical trial platform. So although they've submitted also for the rollout, I mean, to be approved, not only for the trials, still it hasn't been, but we hear that the FDA in the US, they've already approved it. So I'm making an assumption that it will be accelerated for them to be approved. So there's no approval. Same applies, we hear that Pfizer, they did make a submission, same as the Sputnik, they made a submission. So at this stage, there is no vaccine that is SAPRA approved. And therefore, for us, with the Western Cape, therefore, it nullifies in regard to what is the budget and also whether we have bought any vaccine or whatever, because there's no official approval of any vaccine at this stage. Remember, we said then it was a contingency plan, as we always plan ahead, so that in case there might be a need where we need either to supplement national, or if it so happens that we get a go-ahead in regard to, because as you know that in terms of legally speaking, it doesn't stop us if we want to be able to procure at the time, when the time is right, and also at the time when, as we have seen with the other immunizations, child vaccines and all of those, where anyone could be able to do it, especially the private. So that's where we are. So we are still within the national program, and we are in the implementation study phase. Not even, as I indicated earlier, even throughout the country, there is no other vaccine that is being rolled out now, except for the one for the implementation study. The list, traditional healers. Yes, in terms of the phase one, in terms of the definition, healthcare workers is the healthcare workers, both public and private. That's why even with the allocation of the vaccines from the national side, it has been 2/3, 1/3, 1/3 for the private. Also, the healthcare workers include those who are in our provinces, working in our provinces through PESAL, and also those who are working like in the city health. Same applies in other provinces, like in the eThekwini and all of those. They're not necessarily part of the provincial health staff. It's also students, health sciences students, be it the medicine, the nurses, and all of those when they are on the platform. It also includes the community health workers. It also includes the care workers, those who are working in the old age homes, in the social development space, and all of those. It includes the traditional health practitioners, as according to the definition of the Traditional Health Practitioners Act of 2006. Also includes the complementary medicines, as according to the modalities, according to the Allied Health Act, which is the acupuncture and all of those. So they are part of that. So that's why when we were sharing our vaccine rollout at the time we were dealing with the AstraZeneca, already we engage with all of these that are not necessarily part of the conventional health system, because it's easier for the department to engage, because they already engage with staff within our health facilities, conventional health system, same as with the health sciences, similar with the others, but with traditional health practitioners. So that's why I engage with them. I think we had about 3 or 4 sessions, and then we put a pause after AstraZeneca was put on hold. So where are we now? The question we're asking about where are we now? They're still part of the phase one, but as indicated earlier, you still have to do the sequencing, even for the conventional one. So whilst we know the GCF QV has the methodology, how traditional health healers work, which is the Gabacima Futa Kaba, Kapula Vasa. They are all have got one, as a practitioner, to be exposed less than 1.5 meter with a patient. But again, a similar way that we sequence those healthcare workers within the conventional health system, it's a similar way that we'll be able to do with them. Because remember, even with a conventional one, not even all GPs, make an example of the Tigerberg, because I was there recently. They've got about 7,000 staff members there. So by definition, they are all healthcare workers. I would say you take 10 from the EC, maybe take another 10 from the COVID ward, and all of those, so that equitable access is there, specifically those who are exposed in regard to the criticality in those critical wards, vis-a-vis those who might be working in psychiatry or in CSSD, or those who might be the security that is working by the gate, compared to that security healthcare worker who might be working in, let's say, in maternity, for example. So one has to balance. Lastly, Member Marais, when we spoke about locally produced, we don't have any vaccine that has been locally developed or produced. The J&J is a US based, but with Janssen, their subsidiarity company, pharmaceutical company, Janssen, which is based in Belgium. So we don't have any. However, at the time, it was the part of the discussions in terms of whether there could be a locally company where they can do the fill and finish. But those discussions are happening elsewhere because it's part of the Department of Trade and Industry, because it's a matter of globalization. What we know, for example, about the Pfizer, what the president said, Pfizer one, indicated that whilst Pfizer is also made elsewhere in the US, but they, and also together with a biotech, which is, I think, German, I think so. But they might be where Aspen, based in PE, they could be able to do the fill and finish, which is everything's already been prepared. They just do the labeling and all of those, just as with BioVac has been doing with other immunization, child immunizations, and probably they might even BioVac themselves, they could be able to, but all those discussions, they are between the national and also that involve the issues related to the trade and globalization. Thank you. I think I've covered most of them. Dr. Casey?
Yeah, thanks, Minister. I think you did cover most of it. I can just give the following. The cost for a PCR test is about 600 Rand. The cost for an antigen test is 120 Rand. The recommendation that we make is that PCR, the rapid test does give you a diagnosis. In 30%, when it is negative, we also send those tests for PCR. Our expert committee is saying that the diagnosis with the PCR and the need to refer the diagnosis with antigen is sufficient, and the need to refer for PCR we need to take under review. That's part of clinical recommendations. We are making it available to the national department, and it will be in consultation with the national IMT meeting. The issue about vaccine procurement, as you rightfully say, we have contacted J&J. We have contacted Pfizer. They have indicated to us at this point in time they're providing the vaccines, that they will be in negotiation with the national department. We are not in any process procuring any other vaccines. So we're not procuring any vaccines because nothing has been through SAPRA. And then in terms of the registration for elderly people, when we are ready, it will be made clear what the steps and guidelines is for people for phase 2 to be registered on the system. We would imagine at that point in time, we will make it absolutely clear what the process will be for people to be registered. It's not clear yet. It will come out, and once it's ready, we will communicate it accordingly. As the Minister just said, I just want to illustrate the point. There is no vaccine currently for which there is charges, because the J&J vaccine is free of charge given to this country. Nobody purchased this vaccine because it was research stock. When we do purchase vaccines, it will be free of charge at point of administration. And when we get to that point, everybody that's on a medical aid will be charged behind the scenes, but it will be a single exit price for it. Those regulations are still being put in place. Once it's clear, it will be clear to everybody. And a medical aid has to disclose it to their members anyway, before that payment can be taken off the medical aid. Then in terms of the immunity, the immunity for once you've taken the immunity after the second wave. Member Marie, you are correct. We're saying that there will be immunity after the second wave. We are saying that we will be testing the samples. So we will know in 2 weeks' time what the immunity levels look like. Assumptions about what the vulnerability is and how vulnerable people are for the third wave. So we can't preempt what it will be. And then in terms of trauma load, we have made it clear as a Western Cape Department of Health, we have made clear recommendations about how to mitigate against that. And the recommendations go to the places where we, the appropriate places to be tabled. Thank you very much, Chairperson.
Thank you very much, Minister and Dr. Christie. We still have a little bit of time left in the meeting. Are there any final questions to the department? If I could see by a show of hands, if there are any. Going once, going twice. All right, that then concludes the questions and our engagement with the department. Thank you very much, Minister Mbombo. Thank you very much, Dr. Christie, to you and your team, and to Dr. Valabji for having prepared the presentation. As always, we're very grateful for your time and for answering our questions to the Provincial Parliament. We wish you very well, and we look forward to seeing you again, and especially once we have more information on the seroprevalence results. So thank you very much. The committee will proceed to do its administrative work. You may leave the meeting.
Thank you, Madam Chair. Bye.
Thank you, Chair. I also want to acknowledge, because I see now in the participants, Ms. Janita Arens, who's as Chief Director, who has been assigned to one of the people together with Dr. Valabji in charge of the vaccine rollout. Just wanted to acknowledge that. Thank you.
Thank you, Minister, for that. Appreciated. All right, members. Are there any resolutions or recommendations or requests for information that you'd like to table now? Otherwise, it can be done as per usual via email by 12 o'clock on Monday, the 8th of March. So if there's nothing you'd like to table or members would like to table something further, you may also do so in writing. I see there are some hands, so I'll start with the first hand on my list, Honourable van der Westhuizen.
Yes, thank you, Chairperson. Chair, sorry, there seems to be an echo or other sound coming through. Chair, it has been referred to quite often that the ban on alcohol has made a huge difference to the number of trauma cases being admitted to hospitals. Now, what we know is that there are more than one variable. It's not only alcohol that has been banned or then bans lifted, but also the hours of curfew normally ran together with those announcements. Now, I would like to see to what extent can the Department of Health give us an indication, and I believe that would require a little bit of a study from them, as to what is the effect of alcohol and what is the effect of the curfew hours on the number of trauma cases being admitted. Because there seems to be, from the Department of Health presentations, as if they believe the only alcohol, that alcohol may be the only contributing factor to trauma cases. And if that is the case, obviously we as a province will need to, I believe, embark on a very, very strong campaign to ensure that alcohol is used responsibly. But if there's also other factors such as the curfews, etc., I think it's important information for us to have. So my question would be, can we get an indication what percentage of those trauma cases are directly related to alcohol and what is related to other external factors? Thank you.
Thank you. Noted. Honourable Van Vogel.
Thank you, Chair. Chair, mine is on the district. I'm not sure they call it the district council. Is there a possibility that we can invite them to do a presentation, especially I'm speaking about those in the not Kailua, the West Coast area, because that's where we are getting a lot of problems from. So I'm just asking the possibility. Thank you, Chair.
Thank you. I'm sorry, I wasn't clear. Which entity do you want us to invite?
Chairperson, remember Dr. Christie, I'm not sure if it was the minister, is saying that the district councils, I'm not sure, do they call it the district councils, is where all the stakeholders is serving, like the Department of Labor, the Department of Agriculture, the municipality, those entity. Especially, my focus is now in the West Coast. So my request is, if it is possible, that we can invite them to one of our meetings. Thanks, Chair.
Okay, is that for the vaccine rollout?
That's in terms of, remember, there was an issue regarding we need a whole society to fight this epidemic. So we need, and I'm always refer back to that district council by the minister and the HOD. When I mentioned the farm workers issue, when I mentioned the water issue, then I refer back to that.
Okay, got you. Okay, thank you. Noted. Honourable Murray.
Thank you, Chair. I'm a bit mystified by the answers I received, but I didn't want to push it further. I want members just to give me a hearing. Under phase 2, we decided that prisoners, those who murder our people, rape, they get preference in being vaccinated over and above elderly people older than 60, over and above young people, free-loving people who go to clubs, behave themselves, don't murder anybody, just want to go to a restaurant or clubbing. They last on the list for vaccinations. They fourth. But the prisoners are right up there. They must get vaccine first. In a situation where they are better controlled to keep social distancing, they can go out in the open in the yards of the prison if they want to exercise. They can make arrangements for prisoners to be less prisoners in a cell. But the people outside, the old people who stay in shacks, in confined conditions, they last on the list. How can we let this happen? How can we say that people who sit in jail has more rights and privileges than law-abiding citizens outside of jail? I'm very disturbed by this.
So would you like to pose a question then on how this decision was reached?
Certainly I would, with the support of the majority party, which is the DA. I'm trying to convince people who are level-headed, like Mackenzie and Mr. Van der Westhuizen, to come along and say, what do you think of this? Do you really think that prisoners should get more privileges than people outside of jail?
Oh, sorry, I didn't realize I was still on mute. Okay, thank you, Honourable Murray. We will include that. Honourable Mackenzie.
Chairperson, I think it was more about the risk factor of the matter, because they were in confined spaces than opposed to what they did and how the virus spread easily in confined spaces. I think that was the reasoning behind it, but I mean, I'll leave it up to you to formulate it, yeah.
Thank you. If there's nothing further then, or if I can ask the members then to pose any further questions or requests for information to us via email. The deadline is 12 o'clock on Monday. All right, we then move on to adoption of the draft committee minutes of the 3rd of February. And I'm going to ask Ms. Hassan Musa to please beam those up. Thank you, very quick. All right, you have received this, which was the last meeting from Treasury and Health. Please check attendance. Any edits or amendments? None. Let's continue. Any edits or amendments to page 3? Okay, if there are none, page 4, can we adopt these minutes, please? Can I have a proposer?
I so move.
Thank you, Honourable Marais. And Honourable Bartman, is that a seconder?
Yes, I second the minutes.
Thank you.
Sorry, I apologize.
Let's move on then to the consideration and adoption of the draft committee report for activities undertaken in the month of January. Okay. I'm not sure what's going on there. We saw it and then it went off again. Oh.
Sorry, Chair, there seems to be a little bit of technical difficulty.
No problem. Here we go. Looks good. All right, so here's the report for the month of January. The first 2 pages are similar in every single report, which is basically the establishment of the committee. We can continue down. Then we move into the themes. Members have all received this. Are there any edits or amendments to page 3? None. Let's move to page 4. Any edits or amendments to page 4? Any edits or amendments to page 5? Any edits or amendments to page 6? Honourable Bartman?
Apologies, Chair. On page 5, I just wanted to check Mitchell's Plain, the name just needs to be spelled correctly, and the P needs to also just be a capital, please.
Thank you for spotting that. It also needs an I.
And yes, I as well. I'm not sure if before it's an E or an A. Perhaps one of our constituency heads, Member Mackenzie, can assist us there. But I do know about the I, yes.
Yeah, perfect. Thank you. Page 6, any edits or amendments? There are none. I think the last page is just, there we go. All right, so can we then adopt with that one edit, correcting the spelling? Thank you, Honourable Bartman. And Honourable Marais, is that a seconder?
I will second that.
Thank you very much. And then the final document for consideration is the report for the month of February. That was circulated yesterday or the day before, so we'll go slightly slower through it. Again, the first 2 pages are the same in all the reports, so we can directly move on to page 3. Okay, so the theme in February was the Health Department update on vaccines, as well as government finance and budgets with the briefing from the Treasury. All right, any Honourable Bartman?
Thank you, Chair. Chair, I'm not sure if that 41, is it supposed to be 4.1 or 5.1? I'm not sure if the 41 and then the 5.1 is in line.
Thank you. Well spotted. That should be a 5. Thank you. Are there any other edits or amendments on page 3? There are none. We can move on to page 4. Honourable Bartman.
Apologies, Chair. There's just a formatting correction between 5.2.10 and 5.2.11. It says there 3.2.11, so we just need to do the numbering, fix that one. Thank you.
Thank you. I wonder how sometimes this auto formatting does strange things. Okay, moving on to page 5. And that's the end of the document. All right, can we then adopt this report with those 2 edits? Honourable
Move to
Bartman.
adopt.
Thank you. May I have a seconder, please?
Seconded, Chair.
Thank you, Honourable Philander. Then that concludes the admin part of the committee's work today. Before we close the meeting, I'd like to inform the committee that we have had a change in procedural officers. We now have Mr. Ben Daza, Ms. Hassan Musa and Ms. Jones assisting the committee from the procedural perspective, so we'd like to welcome them. And we'd also like to give our very sincere thanks to Ms. Lizette Kluter and Ms. Zaida Adams for the 9-10 months of work that they have done and their very professional support to this committee during that time. So thank you very much to Ms. Kluter and Ms. Adams, and we welcome the new procedural officers to the ad hoc committee. All right, so with all of those points done, I'm going to close the meeting now and like to thank all members for their very keen participation in this meeting. Thank you very much. The meeting is adjourned.